Uh, yeah. Yeah. Yeah.
Joining me on today's episode of the podcast is Shawn Eno of Xtreme Footwerks out of Idaho Springs, Colorado. We, as a clinic, have had a long relationship with Shawn, and I actually was introduced to Shawn via my mentor, Brett Winchester, when I was working at Winchester Spine and Sport back in the day. And Shawn has a wealth of information, amazing guy. I just humbles me as my base of knowledge as it applies to biomechanics, in particular lower extremity biomechanics. So without further ado, here is Shawn Eno of Xtreme Footwork. First place.
Yeah. When you've been practicing long enough, you identify the ones who you're not going to get around their pain body, and you just kind of avoid it. I mean, they'll come and see you, and you'll basically have to be honest with them and say, I don't think I can help you.
Yeah.
Here are the reasons why.
Yeah.
And you may not like it. And, as a chiropractor, I am sure you refer people to psych, but as a pedorthist, I don't, I never tell anybody, maybe you should go talk to somebody about this. I usually use the shoe metrics and the biomechanics and the orthotic stuff to kind of just explain to them that this is a case where, I don't want to fail you, so I'm going to serve you up front by saying that I don't think I can make your situation better with the amount of money and time that we would invest in trying.
Yeah.
1 second, Beau.
Yeah, you're good.
Yeah, as soon as the weather warms up around here, we all get busy again.
Well, I guess that's good. I mean, are you a bigger, what's your outdoor sports of choice? Are you more summer? Are you more hitting slopes? I
was struck by a car while riding a motorcycle home from college when I was 19. I went to UMKC, and I got hit at 39th and Broadway and nearly killed, and they nearly kept the foot. And I just begged for it when I was awake again 6 hours later, because there was about 5-6 hours that I missed, and there was good enough vascular flow through the foot that they did the old rod and screw thing. And I ended up with 4 hammer toes, rigid hallux abducto valgus, and they also offset the fibula with the bottom remaining piece forward at least 1/4 inch from the top remaining piece, giving me a left internal tibial torsion. So the long answer is I can bike the best.
Yeah.
But I've one day we did 3 days of stuff, and I had a big vascular flare up, and I was playing phone tag with my vascular surgeon, and because it just wouldn't go away, it wouldn't just heal up like a sore muscle. And after about 3 or 4 weeks, it did. So I got limits. So I have 10 or 11 days on the hill snowboarding. I'm aggressive. I'm just 53 now instead of 30.
Yeah.
And then I bike because I can't run, and I hike as far as I can hike before I develop pain and suffering from that. And that's usually actually perineal issues or blistering.
Yeah. What a hell of an intro to a podcast. We're already recording. I'm just leaving that in, man.
Yeah. I mean, it's been a guiding factor, because one of the things that I found as I worked my way through the industry was how very few people could really build an orthotic that could change the gait and be comfortable, right? So sadly enough, after 18 years of owning a foot orthotic lab, we've learned a lot of the secrets as to why 90%, 9 out of 10 pairs of orthotics are a rigid polypropylene device dispensed by a podiatrist. And it all comes down to the material, whether it's millable, and how much waste versus outcome product there is, So we do it the old method. We pour casts, we thermomold materials, we grind to pedographs, and we take third dimensional information in the form of video from our providers or whatever they want to send us or tell us on the design form consideration. And then, we're prepared to, instead of saying something to you like, orthotics don't work for everyone, which is one of the big boys' taglines, is we say, yeah, send it back to us and we'll make some changes to it and try to get this thing to work.
Well, that's for people listening. We'll get there, but I want to kind of give, now that we've kind of honestly heard your, kind of origin story, the reason I wanted to bring Shawn on, which we've never met face to face. I guess this is a digital face to face meeting, but I've worked with you for now. Since we got in practice almost a decade ago, because I used Brett. I was an intern at his office and I got the process down and was doing fittings at his office. But I wanted to get Shawn on here because we have many shared clients, obviously, but one shared client that kind of went above and beyond. And at one point, I was going to fly out with the client to see Shawn, which I wanted to because I just wanted to see the lab and get to hang out with him and meet him in person. And then that client actually, on his own, went to Shawn's lab and had another pair of orthotics made. And we'll kind of give that story. But what I wanted to my first question, honestly, was the process, right? Which I just wanted people to know that aren't familiar with, what is the orthotic fitting process, but you kind of just went through it step by step. But what is it, your expertise that's the differentiator here? Is it something in the process itself that differentiates you, or just a little bit of both?
Well, so I studied geology and gravitated towards physics in college and materials. So I have a pretty good understanding of Newtonian physics, and I understand that alignment issues with progression type exercises, whether they be forward progression or side to side progression, frontal plane progression, there's different examples we can give. Two are running and skiing, conversely speaking. And the concept of a level pelvis riding along two fairly similarly efficient functional limbs, right? So if we just talked Pinocchio for a second, what would be ideal is two straight 2x4s for femurs, two straight 2x4s for tibia fibula, and then two level tripods at the base of those bottom 2x4s with hinge joints and hip joints, and a level cradle or 4x4 for the beginning of the spine to rest in, right? That's what would function. That's what you'd build your robot to do, basically, right? So if that's the case, because of the physics of planetary physics and moving in planetary physics on man-made surfaces, because really almost everything that we do now is, besides certain sports, is done on a level surface, right? And it all depends on the physics of the activity. But let's just use our city running population, the people who are running several days a week and then hitting a Saturday race, right? That's all sidewalks and streets. So scratch back just a second. You have that ideal biomechanical vision using boards, and then you have the reality of the way that humans are born and develop and their bony structure. So our first attempt is to identify structural deformity. Then the next realization is what kind of compensatory soft tissue involvement must there be to try to offset said biomechanical deformity. So once you identify a structural deformity, you immediately know as a biomechanical assessor that they've got to be working around that, so to speak, right? They've got to be doing more work on that side to get around that, especially if it's unilateral. And a lot of times it is, right? A leg length difference alone will produce a difference in function, long side, short side. But at the end of the day, if we talk levers and moments in basic physics, a short leg is less efficient than a long leg. So you're not getting the same propulsive outcome from the short-legged side as you are the long-legged side. So then what does the patient do to make up for that? One example is they fire their calf extra hard at toe off to get that hip to carry along at the same spacing and speed and frontal plane alignment as the more efficient longer limb. So anytime you can identify a lower quarter deformity, and most of these are tibial, and one of my thought processes on why that is because when a child is in utero and getting really tight inside their mom, the longest bones affected by the rounded womb environment are, because arms are shorter, not really arms. You wouldn't see this in forearms, but you're going to see the possible effects of that really small mom giving forth to a child with curve or twist deformities in the tibia. So that lends itself directly to what you might want to do for an introduction here to, our subject. I don't know how we're going to go about that. If we're not going to mention names because of any regulations, then in essence, what happens is in any sport, if you can't line the hip, knee, and foot up with the foot and the heel being on the same plane, because there are twist deformities in the foot, whether the books and the guys who write them believe it or not. We've got people with true forefoot valgus, and we have people with true forefoot varus. It is a twisted deformity of the foot. It may very well have resulted from that foot being tucked up against the side of mom for the last month, right? And turned in and abducted and inverted and basically somewhat dorsiflex or plantar flex slightly, right? And then their development in the first few years, they don't get back down to straight. They don't get a straight foot. And then they begin to compensate as they gain weight and they go through the second phase of walking, which is when the arch forms. So you get your patient seated in front of you, you line their femurs up. You're looking for their knees to be hanging off the edge of the table. And from right there, you are able to analyze the lower limb from the knee down, so lower quarter, knee down, both frontal, transverse, and sagittal plane alignments. And if those feet aren't sitting there looking like they're ready to hit the floor as soon as the person jumps off the table, straight and flat, they've got something going on. And they have to go through a range of motion adjustment. So in any sport that's weight bearing, like running, walking, golf, there's efficiency lost if one side works better than another, then especially. But if both sides work horribly, then, they're inefficient, period. And I tell these people laughingly, try to get them to keep their humor in practice, but I say, you're not a runner, you're a swimmer. You have, propellers. You don't have the best feet, you've got propellers. Just because there's a twist in them, or because you have a lot of tibial varum. But the other one that's a killer is either to be pigeon-footed or duck-footed, and that rotation to be sourced in the tibia. So it's not present at the hip, it's not femoral, it's not anteversion, it's not retroversion, it's occurring from the knee down. So then in essence, what would we say, us practitioners that know what joints will put up with the most pain and suffering, you're going to, generally speaking, be either advised or subconsciously guided to keeping your hip and your knee in the sagittal plane, the direction of progression forward, and to whatever compromise is necessary at the foot level. So if you have an external tibial torsion like our patient, then also a forefoot varus presentation in the foot. Keep in mind the other thing about the difference between resting something on a tripod versus for the shaft of the tripod to be in Earth's gravitational axis, one of those legs is not on the ground, right? So then it has to tilt to have three loaded legs. And then like a spinning top, it's being pulled over by gravity because it's not in Earth's gravitational axis. So there's actually a gravitational acceleration component on the bone. It's those individuals that with that kind of collapse, they can't keep their knees and hips in the right position above their feet. And everything in the kinetic chain above it goes out of whack. They do fairly well for a certain amount of time in their attempts to compensate for these issues through muscles and ligaments, but if they simply don't have the possibility of establishing a tripod out of their foot while maintaining their knee right over the center of the midline of the foot and their hip right over the knee, then everything collapses on that side.
Well, I have a bunch of questions now before we get to the subject, if you're game for it, because you just opened up Pandora's box for me being a kind of mechanics and running nerd. First one is kind of hits home when you were talking about, versions and, torsions, in particular tibial, because my nephew was diagnosed with lymphoma at the age of 3. And, there's a whole lot of theories, like what was present before, post utero, and then developmentally as he maybe changed a bunch of things. But now they're talking about, multiple surgeries of, basically fracturing the femur, creating external rotation, doing that at the tibia, and then doing that multiple times because he's 52 degrees on one side and 39 on the other. And it's, and his feet, like you said, it's all of that compensation. He's trying to align, the hips and the knees and sagittal plane, and, one foot's, almost pointing directly in, the other one's close. And it's like, I saw this coming, and you hate to be the family member that's like harping, but now, we're in an age bracket where, a lot of rehab's not going to have bony change, which leads me to my question. We're talking about how a large group of people have these issues. You're familiar with the DNS world, and there's this thought that around 30% of people fall outside the normal developmental schema. Do you think, you mentioned the in utero part, but I know the tibia is one of the last places that you can like fully, you can have a lot of change on the tibia later into life in your 20s. Do you think a lot of that is also changing throughout life? Like we're creating more version or verum as we go through life rather than just in utero and then it's set in motion through development? And how many people do you think are dealing with that in general? Like a percentage, like you think 50% of people walking around have some structural issue that could use some help, or is it higher or lower than that?
It's higher than that. In fact, I would say if we had 100 people standing in a room, we'd be hard pressed to find more than 8 to 10 of them with truly straight tibias.
Okay.
So when you think about walking on a natural surface, like, and if you think at all about the branch of animals that we're associated with and the spherical development process that is associated with this, and not to offend any of the religious people out there, but at the end of the day, we're doing a lot more pounding on a lot more rigid surfaces. F equals ma. Those surfaces, according to Newton's second law, are basically turning around and pounding your 180 pounds right back into your foot as you run.
Whoa, Shawn. They just found out that gravity doesn't hold up under the rigors when you go down quantum mechanics. So come on, man. No.
I know. That's when you need some floaters, right? I think they're called hokas, but
yeah, there you
we'll
go.
talk about those later. But in any case, the bottom line is if there was some movement underneath the outside of these people's feet, then what you're saying basically is there really a setup? And I'm saying, yes, there really is, that most of us have some degree of tibial varum.
Mm-hmm.
That's a frontal plane deformity.
Right.
Then if we looked at percentages of external or internal tibial rotation deformity, those numbers become lower, right? Maybe we're talking 1 or 2 out of 10 people have one or the other, right?
Okay.
But there's always that guy or girl that's got, ever since they were a child, their parents could see one side didn't look like the other.
Mm-hmm.
And that's whether it's genetics or whether it's a in utero situation or developmental, the outcome is still something we can track, but I don't think we'll ever see that person outgrow what we're witnessing at 2 and 3, at 12 and 14. That doesn't happen. So if we did an assessment of tibial varum and we took an individual and measured it at 2 and 4 and 6, 8, 10, and so on, we would see this tibia develop in this curvature. Why? We can speculate, but yes, and it remains. And then if we use the concept of the joints taking up the slack, then in essence, what you're talking about as they get older is that knees or ankles or midfoot or subtalar joint or posterior tib complex or perineal group finally throw up a white flag and say, I've been doing this for years for you, and you didn't know because you didn't have any symptoms, but now you do. Why won't it go away? Because it's always been here. I just didn't bark at you until you turned 52. Yep. And now I'm going to bark at you every day until you help me out one way or another, or stop doing what you're doing.
Which is just a prime. I mean, how many times in practice, you have to go through that explanation because somebody's like, I've done this forever. Why now? Which is a good question, right? And then that is the explanation that comes up time and time again is your compensatory capacity just hit its limit, right? Whether it's neurologic, structural, whatever it was, that's the end.
Right.
In school, in school, even in textbooks, and then from different ideologies, when we're talking specifically about leg length inequality, numbers get thrown up of when we need to start, kind of paying attention. And you mentioned, that will have a direct correlation to one side working, what do we want to say, quote unquote, better or worse than the other. What is that like? When do we need to start paying attention, in particular for fitting or within the clinical setting?
So, I like to bring a person into the room and watch them walk. And if there was a number one indicator, say you're at the airport and you don't know anything, if you see somebody walking along and their chin's moving side to side as they walk, they either have a leg length difference or they have one bad toe or something like that, right? They're no longer walking equivalently. So what happens is instead of the hip rotation that should be right underneath the sacrum at the center of the pelvic axis moves towards the more efficient limb, the less efficient limb. So the more efficient limb actually rotates around it.
Right.
It can stride out longer. The other one's more of a crutch.
Yep.
So there's little things you can see. You can look at somebody's pants. You can look at their belt. You can look at their shoulders, but you then have to take a spinal component. You can't just say, hey, their left shoulder's low, they have a left short leg. That's not always the case. In fact, half the time, if somebody's been dealing with a leg length difference and their pelvis is, say, leaning to the right, they're going to move everything to the left to keep the general axis of their body once again in Earth's gravitational axis. And that's the thing with older folks when they fall, is they start losing that coordination to compensate for something they maybe never knew they had. And all of a sudden, they miss the floor with one heel and down they go. So I had a kid in the other day. He was 6 years old, and his dad said he looks short on that side. And I go, I agree. I go, but I just have a hard time putting kids on a lift when it's not severe and obvious, because I also have a young lady who has a 5.5 inch short limb, and that limb's never going to be any longer than the other one. And it's some type of developmental issue. When she was young, something stunted that one side so her femur is shorter, her tibia and fibula is shorter, her foot is smaller, and everything like that. So I said, but in this case, your boy doesn't look that bad. I think we need to at least get him up into the age 10, 11, 12, where things become a little harder, and if it's still there, then we consider treating it. But I've had kids as old as 16 come in with a leg length difference presentation, and I've got certain methods for seeing if I can see it in the tibia, because if you align the medial malleolus of both tibias and you look at the tibial horn, if it's in the tibia, you'll see it right through their skin. You don't need an x-ray to see that. If you have them sit in a certain way, you can also see that either their femoral head or their femur is involved too. And you can determine rudimentarily, okay, I'm not talking from research here. I don't want a bunch of guys calling me up, you don't know what you're talking about. But if it's obvious, then you'll see it. You can pretty much figure out which bone or portion of the leg it's in. As a non-chiropractor, I always believe that there's a double component to leg length differences, at least. Okay, sometimes there's situations where it's mostly soft tissue and there isn't a true anatomic leg length difference. But most times there's a little bit of both. And a lot of times there's a definitive anatomic short limb, and all it would take is one tibia to be more curved than the other one to produce this. So if you have one leg folded over the other like this in utero, and your limbs are very plasticky in that environment, there's one argument for it. Okay. The guy who just about broke the 2-hour marathon has some of the straightest legs you'll ever see. So did John Stockton from the Utah Jazz. I'm aging myself, but he and Malone, back in the day, he looked like a robot on the floor. And if you want to ask the question, well, what sports do we look at that have a tendency to weed people out due to biomechanical deformity? Now, I'll make an addendum. There are these freaks that somehow get around.
Priskett Jeb too. Yeah.
A lot of times their careers are shorter, but while they're there, they just really crush it, right? And they're Olympians and whatever else. But those sports are so hard, like any court sport at all, will simply bring out the worst cases of biomechanical structural deformity, as well as soft tissue compensation and movement compensation, movement pattern compensation, fascial compensation, that they can't make it to the professional level. So you look at the pros, you see the guys with the straightest, best biomechanics.
Well, and I always say that endurance sports put everything under the magnifying glass. So if you have some minor structural abnormality or compensatory mechanism going on, and you do that thousands of times and hit a, motor output endurance, window, and now mechanics go down, I would agree that I think people are really good compensators. I think there's something there too of genetics, of tissue quality and motor control, that you'll have, outliers for sure. But I'm just curious, this question wasn't in the prop, but is that different with sprint athletes? Because we actually see that maybe a Verum moment can help create some torque around the lower extremity with a sprinter.
Well, typically sprinters are usually, so we have a scale of foot type that also impacts all of this, right? So on one end of it, you've got the cavo-rigid foot, and on the other side, you have the hypermobile pronatory foot. And in the middle, the ideal is a little bit of adaptation and the ability to resupinate, and possibly a fairly rigid midfoot, and not too much subtalar or calcaneal pronation or eversion. But we've got individuals with equinus deformities that they're so rigid and have their foot attached to a tibial verum that they're supinatory, and they have much more movement and inversion, and they tear up their perineal groups because they can't pronate at all. Those are the ones you chiropractors should be mobilizing as much as possible, right? And then you got the other ones that walk in and they're so overpronated that their knees look like teepees, steeples basically. And you're like, oh my Lord, their naviculars are on the floor. We got to do something about this. We got to pick them up to neutral. But in either case, what the goal is when you see that is to try to do something to the foot that places the best alignment that you can find for that individual's anatomy between hip, knee, and foot in alignment, right? The problem is, and I love this analogy too, notice how certain way driveways are built. There's only a certain degree anyone's going to pave a driveway before they look at it and go, nothing's going to be able to park on that, especially in an ice storm. Well, that's the same set of physics when we're dealing with trying to correct this kind of stuff. If shoes are malleable in the frontal plane and we're trying to manipulate a foot by inverting or everting it, and in 3 different locations, let's talk heel, midfoot, and forefoot. And in the midfoot, we'll include the subtalar joint, which is kind of both heel and midfoot, right? Somewhere in the middle there. But if we're trying to push on them while the shoes are just subsiding against our work, then we don't get the outcome we're looking for from a custom foot orthotic, because the shoe interferes with our treatment protocols. So a lot of times those patients are also hurting, so they're being guided towards a shoe that's softer, but it's softer in the sagittal plane. And it has no resistance to any deformation caused by biomechanical deformity in the frontal plane, and it ends up wearing out into a position that creates even more compensation for the patient.
Yeah. Well, I heard you actually say on Brett's podcast or Gestalt podcast of using sometimes preliminary or the first pair of orthotics to actually pull out the major movement compensation. And I mean, I think sometimes you can fall into that by accident, right? By doing that. And then the footwear is not being maybe dictated by the practitioner, and you kind of exacerbate that thing, which wasn't, sometimes it is a plan, it's going to happen, but it's part of the process. Sometimes it's not. And you're like, oh, it actually wasn't the wrong thing. It just, you didn't have the right kind of grouping of, shoe orthotic, or you have to build it a little bit different.
Yeah. I tell everybody who takes an interest in providing their patients with orthotics to make the shoe the beginning of the genesis of their dialogue when it comes to the idea of providing them one. Because you can do the assessment and the evaluation and help yourself with all the other modalities that you're using to treat your patient just by identifying the cause, right? Which is usually a structural deformity. Let's trace it back to your question, though. The first ray, in a particularly more flexible foot type, is capable of breaking down and producing an adapted, acquired forefoot varus appearance. And in the medical journals, that's called acquired adult flat foot. Then the question is, would we have seen this twist in this kid's foot when they were 8 that we now see in their foot when they're 35? The way that can be assessed for is it's not. Basically, there are moments where you can be for certain when you're looking at someone that you're like, yeah, they were born with this. It's just, you can tell. But there are other cases where the foot has broken down and it has taken this appearance on through its breaking down. And those were the ones you just referred to, where we can get them back somewhat in the stadium, so to speak, and maybe cast them again and actually get them all the way back from whence they came. And they go through adolescence and early adulthood acquiring these issues before they ever hit your office.
Which is why I like what you said earlier about age appropriateness of putting kids in orthotics, because I mean, I think it's also the time we live in, and what we're seeing with low movement vocabulary is more and more parents bringing kids in that are dealing with maybe what we call pseudo hypermobility issues, right? Which then leads down to the foot, and then they think they want to be thrown in orthotics. So I think that really is something to touch on again is, when is it appropriate to put a kid in? Is it just age? Is it developmental function? Is it what they're dealing with? Obviously, it's a little bit of all of those, but that's something I'm seeing more and more where, tend to be like you, where it's, let's see what happens over time. Maybe there's, if they get into a certain sport, that's going to affect them a certain way. And
like hockey.
Yeah. Hockey, soccer, right? You put them into,
Yeah.
all
Any
these
of the sports that involve pronation as a form of movement, where you have to plantar flex the first ray to get your outcome, is going to draw out where there is a scenario where the individual is already everting and pronating the forefoot to put the foot on the transverse plane. That's neutral.
Yeah.
Then to turn a ski or to take a quick turn in soccer or to push off of a hockey skate, you got to pronate even further.
So it's going up. Yeah.
Right. So the sport can actually help you identify that the person's trying to work around an issue that they have, because they're way less efficient than Bobby sitting next to him that just punks right down the way, right? And whether or not that's trainable or fixable at that age is in question. But I do, like you say, I think that you want to do as little as possible to help, to keep them doing as much as possible to help themselves until you've got some type of either developmental age and or practitioner certainty that this isn't going to go away and that they'll benefit from the prophylactic that an orthotic is, just a bracing or change of function. You'd like to think that you can train it out of them or DNS them out of it. So an answer to your question is, one of the best ways to determine whether someone has the capacity to soft tissue fix a problem is to put them in a DNS short foot with a lot of their weight on the table, right? And if you get that to come into good shape, then there's a good chance that you can rehab, advise. But let's keep in mind that none of us was meant to stand and walk repetitively on man-made surfaces. And only dancers and certain other types of individuals who move in a spherical manner maintain enough strength to combat that reality versus an individual like an indigenous Amazonian or an Australian Aborigine, just by virtue of taking a different step every time they take a step somewhere, they are maintaining the strength of their foot instead of the redundancy of what happens on most of our first world surfaces.
Well, that's a beautiful lead into my sport of choice and my next question, which is trail running. And I'll go after the running in general first. So you're as well aware of I am is when somebody goes into a running shoe store or a shoe store, they're usually fit for a running or given suggestions on a running shoe based on how they're walking back and forth across, the shoes. So when we're fitting an let's break down a couple of scenarios. So scenario one, let's say we're building an orthotic for somebody that's actually having a running issue, right? The injuries being sussed out when they're running. We get them in the clinic and say it's that runner that mile 6, every time, or mile 16, they break down or a certain volume, but walking around, very little pain, highly functioning, and it's kind of in, that realm. How's that change what we're doing with an orthotic? Because now you're moving away from walking to another specific movement, which could be wildly different if they're not a hybrid runner.
Right.
So what do we do in that scenario?
They have to have the sport specific orthotic in that case. In essence, what they want to do is they want to say, hey, first of all, you as the practitioner have to realize that when somebody has a forefoot instability, which is produced by either side of the foot, fifth and first, not being on the same plane as the heel, then they'll have a tendency to shift back because they get more stability out of the heel. So these are the kinds of people that are poor sprinters. They can't get into even a midfoot running stance for like a long race. And they're doing it because they don't feel confident on the front of their feet. So then you have the ones that are sprinters and they still have some collapse before they get on the first ray. and they do want something more aggressive for the running situation, but they don't want to hang out on it all day at home or at work.
So then let's flip that around. So let's say somebody is coming into my office and they have an issue with, everyday stuff. They're working on a man-made surface. Maybe they work at Lowe's or something like that. They're having generalized foot pain, but every day after work and on the weekends, they're an ultra endurance runner and they're out pounding the trails on a variable surface in a different kind of shoe. What are we doing in that scenario with the orthotic that they're wearing on the daily? Are they still wearing it when they go run in that scenario or no?
Well, if you have a treadmill and you can see significant increase in either eversion or inversion when they go into more of a 4-foot loaded type running pattern, right, where there's less time spent on the heel, then you want to treat them for it. Because they're going to go through the same range of motion in the woods. They just have to get used to having some help.
Yeah.
And you can't really, like we want to sometimes put 10 and 12 millimeters of 4-foot varus on somebody's foot. I had a gal in here today. I mean, it was like her deformity was structural and at least 30 degrees.
Oh, wow.
And there's no way.
Yeah.
Right.
Too much.
She's just happy to be walking.
Right.
And but when it's a runner and they start complaining of like great toe pain, then we're looking at like a short first metatarsal Morton's toe, or we're looking at a little bit of 4-foot varus that becomes way more problematic for them when they're in the running gait versus walking and standing. So you want to give them a little more love in that scenario, especially and you can approach it from a basic standpoint. You can get them on a set of orthotics and don't do much posting at all. Just do a good cast. Right. And then reassess later and say, hey, I think we still need some help in the last third of stance phase, because the shell and the orthotic don't do anything as soon as the foot comes up onto the ball of the foot. If there aren't 4-foot features, they might as well be barefoot. It's what's happened until then across the orthotic that
puts them into a position to optimize, but they still have to do it. Yeah.
Right. So you have it's tricky with the runners that collapse medially, because you don't know whether you have to kind of do your structural and your pedagraphic assessment to figure out whether you just have like a Rothbard's Morton style foot or you have a true twist in all of their metatarsals. And in most cases, when it is a true 4-foot varus or a really severe Morton's toe, it takes the rest of the foot down to the ground with it.
Well, that's a good segue into our client that we're going to talk about. But I have actually I'll ask a personal question almost. So I played football for a long time, dealt with turf toe on one side, which could be just activity dependent because it's unilateral bias. I'm just curious, is there something you see associated with turf toe more often than not? Like
is there a cleat involved?
Yeah.
It's the cleat.
Yeah, and that's kind of what I figured you'd say. The reason I ask is you see a lot, or I see a ton of trail runners. When we see somebody make the move from a traditional running shoe, let's say some sort of, Brooks Ghost or something like that, into a Hoka because their buddy wore it or somebody told them, I see a lot of people develop a turf toe-esque, like, flexor hallucis longus, tendinosis kind of soreness from
they're
that.
Not using it because the rocker's built into the shoe.
Right.
So I often respond, I go like, if you already have a hallux rigidus, then by all means get that Bondi X.
Yeah.
But if you want your toe and your forefeet to work normally, you want to do these exercises I have for you. And I usually give them some, DNS short foot and some scrunches and some inversion, eversion exercises, and give them a TheraBand and tell them how to do it. And I tell them, you don't want to turn these plantar flexors off. You want to engage them. But I still firmly believe that a little bit of positive heel helps. There's just such a ton of compression at heel strike. So I'm not a huge fan of zero drop shoes, except for the best athletes. But Topo has 3 and 5 millimeters. So I've been putting a lot of people in Topo instead of Ultra. And I also think that the toes, the fifth is supposed to act like an outrigger.
Right.
And here's the shoe just doing this to it.
Yeah.
You can't even get it out there and on the ground, and then if you're going through repetitive eversion because you have tibial varum or forefoot varus, you're going to end up with it hammered anyway, and by the time you're 60 it doesn't even print.
Yep.
But the rigid cavus foot does the same thing too, because they're falling off the front of it.
They start
and
curling
so they're
under.
trying to lift
Yeah.
the fifth off the ground to keep their rear foot, midfoot in neutral.
Well, I always like bringing up Casey Lichtig, PhD PT trail runner, and she did a huge meta-analysis on footwear, right? And should you transition to shod versus zero? And it was basically what you came up in is what you should stay in. So if you, like most of us, were in a normal heel lift,
positive heel, yeah,
right, then that's what, the outcomes were the best because you've adapted to that. I mean, I think that's
right.
what you're seeing from that. So I just kind of always tell clients that piece of information, because I'm like, you could switch and get away with it, but like, if you're doing okay, like, are you actually improving biomechanics by dropping your heel 6 millimeters, or you just open up the window for something bad to go wrong?
Well, you're demanding a greater range of dorsiflexion out of
Absolutely.
your ankle than you ever have before.
And if we had to pick one of the stiffest motions on most humans in America, I mean, there we go.
Yeah.
So, yeah.
And then the next becomes hip flexion, right?
Yeah. So I just think it opens up Pandora's box. And I mean, I went down, I'm self-admitted, went down that rabbit hole. And, while I was in grad school and Redborn to run, and what did I do? I blew up my calves and my Achilles and all the fun stuff, and had to learn like every other person out there. And I didn't get any money from Vibram, but maybe I should have.
Hey, that's funny, because I do want to say this. One of the things that chews me the most is when I see somebody running in a set of Vibram five fingers down the sidewalk. I mean, you couldn't possibly be hurting yourself more than you are right there.
Yeah. Yeah. Which is really funny, man-made meets man-made. And just not a good scenario overall. Yeah.
I don't think they put enough padding in the heels for that action.
No. Well, like I said, you gave me a good lead in, but I had another question. But you were talking about, how the shell of the orthotic is a base. And then when we get into, posting, that's where you're, in your scenario in particular, and this is something that I think is a misconception, maybe with the patient base, but even some practitioners, that posting is to drive function, not support for the most part. So
it's to shorten the range of compensation for the deficit.
Yeah, much better put.
Or to create stability where there is not.
Right.
Because in the case of like the one we're going to talk about, with a forefoot varus, you're standing on a hockey skate. So if you're going to try to translate something over a hockey skate or a tripod, which one's going to be more stable?
Yeah.
Right. Then it turns out there's an external tibial torsion involved.
Mm-hmm.
So if the resultant compensatory rotation of the lower quarter from the forefoot varus is already a ton of internal knee and hip rotation,
mm-hmm.
and then they're also standing there putting their stance based on where their feet go, then they already have a pre-internally rotated right knee.
Right.
So then on a backswing, when you go to load the outside of the foot, your brain is thinking,
maxed.
I'm going to fall over.
Yeah.
So you shorten it all up.
I'll give everybody, let me give everybody the to this, just so they kind of know where we're coming from. So the short of the long, this is a very long story if we told it all, but this golfer, this was we'll say semi-pro golfer, has kind of been up and down the ranks, had an ankle injury, an inversion sprain, walking during a tournament, post hold, stepped in a hole, carrying his own bag, had a pretty bad ankle injury, which now this is years, prior. And then goes on a journey because post ankle injury feels like the ankle never got back, but really the game deteriorated was the bigger deal. Like something happened where the swing was not replicable like it felt like it was before. Which again, we all know golfers are neurotic just like runners, so maybe that was a feel thing, and it's a different subject. But this golfer goes and seeks help from people that are in our field, extremely high level, gets help, right? Things change, but nothing ever sticks. And lands eventually, kind of calling me for a virtual consult. And by that time, he's already had one pair of orthotics made by Shawn, casted by somebody totally different. And then he actually flies out to Birmingham, and we kind of meet and we kind of go through some stuff. And like immediately, the cool thing here that I don't know if you know this, Shawn, that the first question I asked him when we were doing the consult was, because he said that, the swing changed. And I go, well, do you have video of yourself as a kid swinging? And he had a video of himself at 8 years old, 2 years before he sprained his ankle, and then obviously post. And what you're saying mechanically. So if you can get the image of what Shawn was saying, imagine a severely supinated foot where the ice skate edge is, the outside edge of the foot. But due to that, like he said, he's starting at a relative internally rotated shank. And then when you watch this guy swing a golf club, you never see his patella move from the start position. It's like his lower quarter is just locked into place. It was the same. And even one of those videos is in flip flops. So not barefoot, but like not a shoe to kind of guide a lot of stuff. And I go, the swing never changed. That's been the same since you were 8 years old. And he had been told that post ankle injury, all this stuff was changed around his ankle. So that was kind of a light bulb moment for him. And then that's where it made my job easier, because then I got like all this pre-information of, well, okay, something's got to be structural, because you don't just do that for no good reason. Well, that's where went back to Shawn, and I did another fitting, and we started doing some rehab. And this guy had massive change, like gained 12 miles per hour on a swing, which doesn't happen a lot at that level unless you're, just severely inept at golf. And that wasn't quite the case. But why I wanted to bring Shawn on, this gets to the crux of the interview here, is I built an orthotic, and I don't think I'm a schlub, but I'm not Shawn either. And I built it a certain way, and Shawn's going off my direction, right? Like you said, video, casting, pedograph, input, right? Actual hands-on manual exam. And this golfer went about his business for 6 months or so without orthotic, when it was feeling pretty good, but still felt like it's not, like something's off. And we kind of hit a level where I was like, from a coaching standpoint, not just the injury, I was like, you just need to go play more golf. Like there's reps, because you're not just getting out and playing, you're just trying to practice yourself to death. Well, like I said earlier, I wanted to go out with him to meet with Shawn, and then I didn't know that he was going to do this. He went on his own, and then when he got a hold of me probably a month ago now, and he was like, hey, check out this orthotic that Shawn built me. And I was like, Jesus, that's almost the opposite of what I built, more or less. The forefoot was way different. So I want to bring Shawn on, and I want to humbly get a lesson from Shawn on like, okay, I know what the golfer told me, but I want to hear it from Shawn on like, okay, why, from what I built and what we now know is going on structurally, was it more advantageous, or at least it seems to. Again, we're dealing with an athlete, so at the end of the day, it'll come down to feel. We can work on mechanics, but he may still come back and be like, this doesn't feel right. And then we got a whole another egg to cook. But what was the big difference between, and I don't even know if you remember the first orthotic, like before even me, but there were 3 sets. So what was kind of the evolution or the change, or what was going on there?
Okay. So in essence, when we pick up the foot in forefoot varus, which is what we did through the pair that you and I were working together on, we also basically put him on to less of his heel and more of the outside of his heel.
Mm-hmm.
So in the swing mechanics on the backswing, you need to be able to translate your hips out over the outside of your foot.
Mm-hmm.
So the first thing, through a structural analysis, I said, hey, you have an externally rotated right foot. You probably were born with it,
mm-hmm.
which means in order for your knee to be in the sagittal plane with your hip, your foot has to be turned out 10 to 15 degrees more than your left foot. So I said, start there. And then I said, secondly, it looks like you aren't trusting what your foot feels like as it rolls into supination on the backswing. We have to give you some rear foot valgus and a buttress, meaning we don't undercut the shell at all, so that your foot hits this and says, oh, I can depend on it. It's not going to go anywhere. And you can keep swinging back against the foot. And then as he comes through the swing, we added even more forefoot varus, but he has that externally rotated foot. So his knee isn't already pre-internally rotated,
Mhm.
right? So his knee stayed closer to a line between foot and hip than it was when he was just lining up his feet. So it was a little rear foot valgus, a little more forefoot varus,
Mhm.
and a slightly more aggressive arch through the process of casting him and seeing that I didn't want to hammer his first all the way down, which is
Yeah. Pick it up.
standard protocol for a cast.
Yeah.
So, and just for the record, I'm not a chiropractor. I make orthotics.
Yeah.
You do a lot of other things I don't do. But when it comes to just making an appliance that gives him the stability he's looking for, I play enough golf poorly to understand this because I've got a different deficit. But he wasn't trusting that right hip.
Mm-hmm.
You could see it in his squat. You could see it in everything. You could see it in his glute development. You could see the whole leg was weak.
Yeah.
And it's because even during the daytime, when he's walking around, he's having a hard time understanding that he's basically spending a majority of his day with his right knee internally rotated.
Which in our world, DNS world, like it's a very common pattern. You see like almost a chronically concentrically loaded glute complex, right? Like they're always catching themselves and they can't eccentrically load that back hip to get into that golf swing, let alone, that first part of, a stance phase, they can't let the glute eccentrically load. So it's just like you're pile driving the hip all day.
Right. So we had to make a couple variations because we didn't want to force too much calcaneal pronation during a squat, right? So the pair he uses in the gym has a very small degree of rear foot valgus, and then as much varus as we can get away with without him tipping off the shoe, and then the right recommendations of a shoe that he could take a right or a left playing racquetball in, and the shoe's not going anywhere,
right?
Or a basketball shoe. So,
which I think this is beautiful though,
to strengthen that leg because it's not going through all this failure through his stroke.
Which that's what I was just going to say. The beautiful part of this is, right, this guy went through, this guy is an engineer, very mechanically minded, which can be a blessing and a curse, but also had worked with a lot of top people. And everybody was latched onto the hip, right? Everybody was getting that, like that. But he had been he was stuck in rehab purgatory, right? It was get your hip to eccentrically load, dry needle it, get it to chill, get yourself to get loaded into the back hip. And this is kind of the question I wanted your input on. So, the orthotic I built, like you said, I was I don't know. You can tell me if I'm wrong. Maybe I made him a little worse because we could see that he, starting from the relative, he couldn't move external, whether it was around the shank or get, loaded, posterior into the transverse axis well into the right hip. But why do you think he was able to gain the mile per hour in that orthotic? Literally I think what we did rehab wise, he had done before. I don't think there was any magic in the rehab. But why do you think he was able to gain that rotary speed versus you put him in a 4-foot varus, so I could push off that almost as he was going through that back.
Right. So your question is, why did you gain the mile per hour or so that you gained from the orthotic that we designed with you?
Yeah. Why? What's the theory?
In essence, you were helping him with every step he was taking, but you didn't recognize whatever the case may be. It's not about you. It's just, like seeing what he's doing. You didn't recognize that he wasn't trusting the outside of the heel cup during this golf stroke. I don't want him walking around on his golf orthotics all day long.
Right.
You know what I mean?
Well, that's kind of what I was asking with the Lowe's work or with running. So there are differences in setting versus just, hey, this is what your foot does, but now you're demanding different things.
Yeah.
Okay.
And depending on what you're dealing with and what sport you're applying it to, you did nothing wrong if he was a runner or a gym rat or anything like that. But as soon as he was in a position where he was trying to depend on the outside of his foot to be a stable structure, and he has a history of high ankle sprain. By the way, another point which I think is vital here is what's the primary plantar flexor of the first ray? Peroneus longus.
Yeah. So
if you tear it or injure it, you're going to get even less plantar flexion out of your MPJ as you did before. So what happened, if I had to guess, when he stepped in that hole, is he took a big slice out of the compensation he'd been in all along for that twist in his tibia and that slight twist in his foot.
So that was the perceived difference that he kept leaning on. Yeah.
Yeah. So I told him, I said, we can't have all this forefoot varus on something that you're doing straight ambulation on. And I know you guys have to walk all these rounds, so that's problematic. But if we're going to compromise something and you're playing golf, we're going to compromise your gait.
Yeah.
If you're walking or running, we're going to compromise your golf. I mean, so your orthotic was dialed right in for everyone but him in that golf scenario.
Which I want everybody listening to also realize, and I'll call myself out. It's not easy to, swallow humble pie, but like, this is why I like Shawn, because literally if you send Shawn a fitting or videos, like he'll ask you questions sometimes and be like, hey, what was going on here? Like, I'm not seeing this, or can you tell me exactly what's going on? But like the fact that like by the time you got him there, I don't know how long it took you to surmise all this. I'm sure it was fairly quick, but like, that's the expertise we need within the realm of our field, because you can't know everything. And like you said, it was like a activity dependent, like also clinical assessment, not just what his foot was doing. You had to watch him like move around and be like, dude, you're not doing that around your hip. That is your foot, but your hip is the deal.
And since he's an engineer mind person, he was also walking with his feet straight, which was producing a right internally rotated knee.
Yeah. That's I would say not even engineers, but like runners and everybody, which me and you, I would love to have a whole other podcast on coaching gait. And is that possible? Is that, it's just people do that stuff to themselves. And I'm like, gait is a byproduct of, about 1,000 variables. So you consciously altering it is pretty tough.
Yeah, for sure. And, the thing about that too is, once again, it boils down to like the level. Are they just trying to get by? Yeah. Do they work at the GM factory floor? Are they running 100 miles a week? Those are the kinds of key issues. And then is their orthopedic surgeon telling them to wear Hokas? And then the Hokas are just like basically deforming under the lateral heel, which is causing them to overfire their perineals. There's a lot of factors involved, and it really muddies up the water when you have basic function, day-to-day activity is like typically the tip of the iceberg, right? And then unless they're a professional athlete and they do something more than they sleep, which there's a few people out there like that, then you break it down from there, and you're like, that's when you have to be able to watch them play or at least swing, and you have to watch them squat. And the one other thing I wanted to say too is if a leg is chronically internally rotated relative to the one next to it, under the assumption that they were both the same length when that person came out of the womb per se, right, and developed, then they have a functional short limb too.
Yeah.
Right. So when you wedge someone with a rear foot post, the ultimate side, the unfortunate but sometimes good side effect is that you've got to grind the angle through the shell so you don't make the mistake of thickening up the orthotic on that side and producing a long leg.
Right. Yeah.
Which is typically what happens when you just apply your own wedge, or you're dealing with, I don't want to rip on any communities, but the way things are posted. Yeah. You set your orthotics on the counter, and you put your fingers in the deepest part of the heel cup. And if they're not level and you didn't call for a leg length post, you're like, what's going on right now? Well, so a lot of times orthotics are decelerating pronation.
Right.
Which means then they don't have to compensate as much for that deceleration and eversion compensation. And you're not going to get it all, but you're going to get enough of it to take them out of dysfunction and take them out of pain.
Which I think is a good note just from, clinicians, or students that may be listening to this getting into gait analysis. I mean, I've heard you say this numerous times, and Michaud and Brett and everybody else that I look up to as mentors is, yeah, you're looking at the amount of, navicular drop or pronation, but the angular velocity is the key. And like, if you can pick that up with your naked eye comparatively side to side, sure. But like, that's what you're trying to control due to the stressors on the passive tissues and the other soft tissues. And like you said, you're decelerating that. That's the thought. You're not stopping it. You're not supporting an arch. You're decelerating. Yeah. That's the thought.
You're not blocking pronation because actually, in most cases, pronation is a compensatory reaction to a different problem. And if you block that, you just create another problem.
Right.
That's why feet break down. Because between rigid man-made surfaces and what goes on above the feet get just crushed.
When most shoes put you into a slight supination position, so you put a rigid foot on a rigid surface and then tell it to, crash over to pronation. I mean, it's just a recipe for awesomeness all around.
Yeah.
Well, you guys are hearing it from the king of what he calls orthotic therapy, which I appreciate. Because it's an ongoing process, right? Like, it's not just get more orthotics, see you later. It's, adapt over time, maybe possibly get them out of orthotics, whatever that picture looks like. But like I said, for any students, docs that aren't, using orthotics in practice, or you're just, didn't even know that Shawn existed, if this first time getting introduced to him, like, I tell people in our clinic all the time, and it's not a sales pitch, like, I think he's one of the best in the world, if not the best. And you can see why. He teaches other people in our profession and other pedorthists, gait analysis and all this, like, just a wealth of knowledge, but also the communication that you can have with somebody like him for your clients. You're literally getting to tap into his expertise. And it's kind of a rarity. It's like being able to call an orthopedic surgeon and be like, can I give you a little input on how you're going to do the surgery? And then you give me some input on like what you're going to do. And, it's like more of a marriage of treatment rather than he does his thing, you do your thing. And that's how you go about your business. So I just want to say I'm thankful for what you do and glad to be able to work with you, man.
Thank you, Beau. I feel the same. And I learn a lot from you guys too.
Oh, cool. Well, hopefully we'll have you on sometime. I mean, I could go down the running rabbit hole all day.
Yeah, we can do it again if you want.
Yeah, man. And hopefully we'll get to meet in person, and maybe we'll be, talking at something soon on running. But I'll put some links to Shawn's website, Xtreme Footwerks. And if you guys have any questions, I'm sure Shawn will be game. But thanks again, man. I'll let you go enjoy your day.
Thanks, Beau. You too.
All right. Thanks, man. Good talking to you. Bye.
We'll chat soon.
Yeah. Yeah. Yeah.